From Microbe TV, this is Infectious Disease Puscast, episode 32, recorded on July 5th, 2023. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are you, Daniel?
Well, I am well, but Sara, it looks to me like you are in a different locale. What's going on? Where are you?
Well, I'm in the process of moving in, so right beyond view, there are a bunch of boxes that you can't see, but I'm
okay.
slowly moving into our place in Atlanta.
Okay. In LA?
Atlanta. Yeah.
Atlanta. Okay. All right. And what are you doing in Atlanta to remind, me, who you probably told before, and everyone else, what are you up to?
Yeah, I'm starting at Emory in September, but I have a little bit of a break in between to feel like a real person again and take a breather.
Okay. Well, you're about to start the most joyful part of your life, being an infectious disease physician, right?
Yeah, exactly. Well, everyone, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I survived July 4th. That's a time when everyone exercises their freedom to do horrible things, including eating food that's been sitting in mayonnaise and roasting in the sun for many hours. But we survived. And if you make it to the weekend, remember to listen to This Week in Virology. Let me start with the article, Clinical Characteristic and Outcomes Among Travelers with Severe Dengue, published in Annals of Internal Medicine. And these are the results from a retrospective chart review and analysis of travelers with complicated dengue reported to GeoSentinel from January 2007 through July 2022. Of 5,958 patients with dengue, 95, so 2% had complicated dengue. 86 or 91% had a supplemental questionnaire completed. 85 of the 86 or 99% of patients had warning signs. 31% were classified as severe. Median age was 34, but a pretty big range. We had 8 to 91. Sort of a split here. 56% were female. Patients acquired dengue most frequently in the Caribbean. After that, it was Southeast Asia at about 24%. Frequent reasons for travel were tourism and the infamous visiting friends and relatives. 21 or of the 84, so 25% patients had comorbidities. 91% of these folks were hospitalized. One patient died of non-dengue related illnesses. And this is a big one. Common laboratory findings and signs were thrombocytopenia. And surprised, but it's only 78%. I really think of that as coming along, but 22% of the time not. Elevated aminotransferases, those are LFTs for those of you. Bleeding, 52%. Plasma leakage, 20%. And among severe cases, ophthalmologic pathology, severe liver disease, myocarditis, neurological symptoms. Of 44 patients with serological data, 32 confirmed cases were classified as primary dengue, IgM positive, IgG negative, and 12 as secondary IgM negative, IgG positive. So a couple of things I want to point out right there, right? Like, look at those numbers. If you looked at the patients with serological data, remember that whole idea that, it's worse the second time? These folks, severe dengue with a primary IgM positive, IgG negative, very similar to a case we recently had on the inpatient teaching wards at Columbia.
I pulled a paper from the New England Journal of Medicine, a phase 3 randomized trial of BooLavertide and chronic hepatitis D. Just for everyone to remember that Hep D is a small virus that's almost exclusively seen in patients with chronic Hep B infection because of its dependence on the Hep B surface antigen for transmission and infectivity. So about 5% of Hep B surface antigen positive persons are infected with hepatitis D. The overall prevalence is low. And I actually didn't know this. It's low enough that it qualified it for an FDA orphan drug program. There is no current treatment for hepatitis D. And so BooLavertide inhibits the entry of hepatitis D virus into hepatocytes. And so in this phase 3 multi-center open label randomized trial, they were looking at patients with chronic hepatitis D with or without compensated cirrhosis that were assigned 1:1 to receive the drug at 2 milligrams or 10 milligrams for 144 weeks versus no treatment for 48 weeks, followed by the 10 milligram dosing for 96 weeks, so our control group. The primary endpoint was a combined response at week 48 of undetectable hepatitis D RNA level, or a level that was suppressed at least 2 log from the baseline, and normalization of ALT. And then they looked at undetectable hep D RNA level at week 48 as a secondary endpoint. There were 48 patients in the 2 milligram group, 50 in the 10 milligram group, and 51 control. And the primary endpoint response occurred in 45% of the patients in the 2 milligram group, 48% in the 10 milligram group, and 2% in the control group. And then the Hep D RNA level at week 48 was undetectable in 12% of patients receiving 2 milligrams and 20% in the groups receiving 10 milligrams. And the last thing, the ALT normalized in 12% of the control group, 51% in the 2 milligram group, and 56% in the 10 milligram group. There were more commonly adverse effects in those who received the treatment. These were mostly mild to moderate and did not lead to treatment discontinuation, things like headache, pruritus, eosinophilia. The overall conclusion is that after the 48 days of this drug, the BooLavertide treatment, the Hep D, RNA, and ALT levels were reduced in these patients with chronic Hep D infection. There are still some questions. Is a 2 log reduction equally beneficial to being undetectable? Still clarifying the 2 versus 10 milligram dose and more long-term safety. So we'll get more info from the final results. But I think interesting to hear about this and think about how it might be helpful in the patients who, in particular, have hepatitis B and D co-infection in the future, because that's kind of who you worry about having progressive disease.
All right. The article, Increased Peripheral Inflammation is associated with structural brain changes and reduced blood flow in virological controlled people with HIV, recently published in JID. So here, the investigators looked at a cohort of ART adherent, virologically suppressed people living with HIV. Looked at 173. All these folks had less than 50 copies per ml. Immune cell markers of overall immune health, CD4, CD8 T cell ratio, myeloid inflammation, CD16 positive monocytes, plasma markers of inflammatory status, so soluble CD163 and soluble CD14, along with structural volume and functional cerebral blood flow neuroimaging were measured in these folks. They reported that decreased CD4-CD8 ratios correlated with reduced brain volume and higher inflammatory CD16 positive monocytes were associated with reduced brain volume in total cortex and gray matter. An increase in plasma soluble CD14, a marker of acute peripheral inflammation due to circulating microbial products, was associated with reduced CBF, cerebral blood flow, within the frontal, parietal, temporal, and occipital cortexes and total gray matter. All right, another HIV paper, the article, Sustained Viral Suppression with dolutegravir monotherapy over 192 weeks in patients starting combination antiviral therapy during primary HIV infection, early simplified, a randomized controlled multi-site non-inferiority trial. What do you think? How's that acronym there, Sara?
It's good. It's pretty good. I mean, like 3 stars. It's like middle of the, it gets the job done.
All right. The simplified. The early is the problem I didn't like. I would have just liked to call it the simplified trial because really we are simplifying things here, ideally. So published in CID, and here's the idea. And this has changed when I was teaching on the wards this last couple of weeks. I was saying it was really complicated, then it got kind of easy, now it got complicated again. But we think that starting combination antiretroviral therapy during primary human immunodeficiency virus type 1 infection results in a smaller HIV-1 latent reservoir, reduced immune activation, and less viral diversity compared to starting combination ART during chronic infection. So this report is the result of a 4-year study designed to determine whether these properties would allow sustained virological suppression after simplification of ART to dolutegravir, right? So I guess the idea is if you started early, then you could potentially simplify the early simplified trial. Well, early simplified is a randomized open label non-inferiority trial. People with HIV who started their ART less than 180 days after a documented primary HIV-1 infection with suppressed viral load were randomized 2-to-1 to the dolutegravir monotherapy with 50 milligrams daily or continuation of ART. The primary endpoints were the proportion of folks with viral failure at 48, 96, 144, and 192 weeks with a non-inferiority margin of 10%. After 96 weeks, randomization was lifted and patients were permitted to switch treatment groups as desired. Of 101 folks randomized, 68 were assigned to the dolutegravir monotherapy, 33 to combination ART. At week 96 in the per protocol population, 100% showed virological response in the dolutegravir monotherapy group versus 100% in the combination group. And upper bound 95% confidence interval, 6.22%. Now, they reported that this demonstrated non-inferiority of the dolutegravir monotherapy at the pre-specified level. Really, if you got this started in these folks who were treated early, you could switch over to this simplified approach. All right, we've got another one. This is rabies. Hey, how could I skip an article about rabies? This is some folks have been doing for a while. So now we've got a little more science. The side-by-side comparative study of the immunogenicity of the intramuscular and intradermal rabies post-exposure prophylaxis regimens in a cohort of suspected rabies-exposed individuals published in CID. So all WHO pre-qualified rabies vaccines for human are inactivated tissue culture rabies virus formulations produced for intramuscular administration. But due to costs and vaccine shortage, dose-saving intradermal administration of rabies post-exposure prophylaxis is actually encouraged by the WHO. This study compared the immunogenicity of a 2-site, so you do 2 sites in the deltoid per visit versus a 3-visit intramuscular Pasteur de Camboge regimen to the IM 1-site 4-visit 4-dose Essen regimen using ViroRab vaccine, right? So basically what we're doing here, and they have a really cool infographic, and it's hilarious, right? They've got a picture of this guy with I think he must be saying curse words because he's got exclamation marks and he's being bitten in the leg by a rabid dog. Then you've got some people apparently being docilely bitten by a cute kitten, and then 1% of the time it's a monkey biting the person. And then it's pretty much equally split men and women. And so what they're comparing here is this 0, 3, 7 double shot intradermal, as opposed to the standard Essen regimen. We get an IM shot, half a milliliter, at 0, 3, 7, 14. And they're going to be doing some blood samples kind of as they go along. And then what they're going to do is they're going to look at the development of neutralizing antibodies and T-cell response in these 210 patients with category 2 or 3 animal exposure. Now, what is category 2 or 3? So this might be a nice primer on WHO rabies exposure categories. Apparently, category 1 is touching or feeding animals, animal licks on intact skin, which is actually considered no significant exposure. Category 2, I like this, nibbling of uncovered skin, minor scratches or abrasions without bleeding. Maybe that's the cat's nibbling or something in that abstract. Category 3, this is the real stuff, single or multiple transdermal bites or scratches, contamination of mucous membrane or broken skin with saliva from animal licks, exposures due to direct contact with bats. This would be a severe exposure. Now, at day 28, all participants developed neutralizing antibodies irrespective of how you did this. T-cell responses and neutralizing antibodies were similar for both post-exposure prophylaxis schemes. So basically what they're going to say is this intradermal approach, getting those 2 shots in the deltoids on day 037, is as effective as that 2-week IM 4-dose Essen regimen. And it only requires about 1/7 of the amount of vaccine. I did the math there.
That's great. I'm assuming I have not received an IM rabies vaccine, but I'm assuming the intradermal also is less painful.
I mean, all my rabies shots, I love to be able to say, all my rabies shots have been, intramuscular.
Yeah.
Apparently, I realized I was like petting a lot of dogs and having a lot of wildlife exposure in areas where, boy, it would really be quite something to get to a place where I could get some, immunoglobulin. So I went ahead and.
Yeah. Well, I will take us into our bacterial section. Be sure to check out This Week in Microbiology as well. I pulled a paper from a journal that I feel like we occasionally pull stuff from, the Critical Care Medicine, and it is Reliability of Admission Procalcitonin Testing for Capturing Bacteremia Across the Sepsis Spectrum, Real-World Utilization and Performance Characteristics, 65 U.S. Hospitals, 2008 to 2017. So this was a retrospective cohort study that used a Cerner database and looked at adult inpatients who had blood cultures and procalcitonin drawn within 24 hours of admission. At these 65 hospitals, about 75,000 of the 740,000 patients, so about 10%, who had both an admission blood culture and an admission procalcitonin test. I said basically it was about 10% who had both blood culture and procalcitonin. Most of those patients, 83%, did not have a repeat procalcitonin test to follow up. The authors found that the procalcitonin on admission demonstrated poor sensitivity in ruling out bloodstream infection. So using a cutoff of 0.5, the sensitivity for bloodstream infection detection was 68% overall. Moderate to poor discrimination for both bacteremic sepsis and occult bloodstream infection, and it did not appear to meaningfully alter empiric antibiotic usage, which I think makes sense if you have just a one-time admission procalcitonin. I wonder how helpful that is over just your clinical assessment of the patient, particularly if we're not following it up with anything, but maybe that is a little bit of a bias that I have against how actually useful procalcitonin is.
Okay. We know how you feel there, Sara. Well, the article, Early Discontinuation of Antibiotics in Patients Admitted with Clinically Suspected Serious Infection, but Negative Cultures, Retrospective Cohort Study of Practice Patterns and Outcomes at 111 U.S. hospitals, published in Open Forum Infectious Disease. Now, in this study, the investigators compared outcomes in patients with culture-negative serious infection treated with 3 to 4 versus greater than or equal to 5 days of antibiotics, right? So this is, person comes in, they seem really sick, you put them on the antibiotics, it's 3 to 4 days later, nothing's growing. Can you just stop? Culture negative serious infection, CNSI, sounds like a cool show, was identified among adults admitted to these folks, to these 111 U.S. hospitals between 2009 and 2014 using electronic health record data defined as suspected serious infection. Blood cultures were drawn, and then folks had to receive at least 3 days of antibiotics. negative culture-based and non-culture-based tests for infection. Antibiotics were discontinued in 3 to 4 days in only 9% of the patients. Early discontinuation was not associated with a higher mortality odds overall in patients presenting with sepsis and without sepsis, with pulmonary or non-pulmonary CNSI. So then they do this propensity score weighting, and they find that early discontinuation appears detrimental with propensity score weighting and retaining patients with sepsis mimics. It's sort of an interesting study, and I'm just going to say, I'll give you their conclusion. They conclude that early discontinuation of antibiotics in CNSI, culture-negative serious infection, was not associated with significant harm in our primary analysis, but differing conclusions with different analytic decisions and risk of residual confounding indicate randomized control trials are needed.
I need to read that one. I feel like this topic comes up not infrequently, this magical culture negative sepsis.
Yeah, it's sort of interesting. At some level, I've had this discussion where we say, our, sensitivity is only about 50%. So if they seem really sick, let's quote unquote complete the course, whatever that really means. Maybe that's one Constantine unit. But here's kind of this idea that, well, if the person seems fine and they were low risk to begin with and nothing's growing and here we are, can we just stop? And I think I sort of get the sense that we need a little bit more science to help.
This next paper I pulled from JAMA Pediatrics, short course therapy for urinary tract infections in children, the SCOUT randomized clinical trial, which actually I did like that acronym. I'll remind everyone what that is in a second. But for the sort of non-pediatricians in the audience, the AAP recommends treating febrile UTIs with a duration of 7 to 14 days of antibiotics. But we have pretty limited clinical trials and data in general in children to help define the perfect duration of therapy for UTI treatment. And so SCOUT stands for short course therapy for UTIs. So this is like a 4-star. It's a good trial name.
Was it an outpatient trial? Because I'm trying to put the SCOUT together. I would have liked short course outpatient urinary tract therapy.
It was outpatient and EDs. Oh, I wonder if I left out the O. I think that's a good question. Is the O from the course? Oh, now I have to go back and look at it.
While you're telling us about it, I'm going to take a look.
The SCOUT trial was a randomized, double-blind, placebo-controlled, non-inferiority trial at outpatient clinics and EDs. This was at 2 children's hospitals from 2012 to 2019. For those who wanted to know, it was CHOP and UPMC. They included children that were 2 months to 10 years old with UTI exhibiting clinical improvement after 5 days of antibiotics. So the intervention was either another 5 days of antibiotic, considered the standard course, or 10 days of therapy, versus 5 days of placebo, which is the, quote, short course therapy. So they compared effectively children who got 5 versus 10 days of antibiotics with a primary outcome of treatment failure or recurrent UTI between day 6 and the first follow-up visit, which was on day 11 to 14. The analysis for the primary outcome included 664 randomized children. The median age was about 4 years old. 2 of the 328, or 0.6%, who were assigned the standard course, versus 14 of the 336, or 4.2%, assigned the short course, had treatment failure, with an absolute difference of 3.6%, 95% confidence interval, 5.5. So, sorry, I should say that again because there were a lot of numbers. Basically, the standard course 10 days, it was 0.6 who had treatment failure percent versus 4.2% in those who got 5 days. And then in the secondary outcomes, children receiving short course therapy were more likely to have asymptomatic bacteria or positive urine cultures at or by the first follow-up visit. But there were no differences between the groups and rates of UTI beyond the first follow-up, or differences in adverse effects. So children who got 10 days had lower rates of treatment failure than the short course of 5 days. although the 5-day, said a different way, the 5-day course failed to be statistically non-inferior using their 5% margin. But the authors concluded that the low failure rate of the short course therapy suggests that this is still a reasonable option for children exhibiting clinical improvement at day 5. So I took just kind of some notes. The first is that this must have been a lot of work by the investigators, and there was very little loss to follow-up. So I think that was a really great strength of the paper. The sort of drawbacks is that UTIs were not differentiated into cystitis versus pyelo, or sort of upper versus lower tract disease. And even though that's sometimes more challenging than not in children, I think we can't really know exactly if the treatment failure might have occurred more often in patients who had pyelo rather than cystitis, which is a pretty big differentiator, at least when we think about this from what we've learned from adults. The 5 antibiotics that were used in the paper were amoxiclav, Augmentin, cefixime, cefdinir, cephalexin, and trimethoprim sulfa. Having multiple agents obviously can complicate things. We don't really know if there's a difference between oral beta-lactams versus Bactrim versus fluoroquinolones. And, I think people have different thoughts about their comfort relying on oral beta-lactams. We often use these in pediatrics if we can over those other 2 agents if it's possible. And then based on the trial design, they're sort of different follow-up times sort of built into how it was designed that might introduce some bias, right? So the children who got 5 days of therapy were effectively monitored for about a week after stopping their antibiotics, compared to children who are on the 10-day arm who are really just being monitored for, a couple additional days before that first visit at day 11 to 14. So it might lead to the false conclusion that 10 days of treatment is superior. So, the authors argue that the treatment failure in both arms is low, 5 days is reasonable. I mean, I have to agree, my gut is that 5 days or less is probably okay for cystitis. I don't really know for those who truly have pyelonephritis or upper tract disease if 5 days would work. But I think it gives us some space to talk about this with anticipatory guidance discussions and shared decision-making with parents, weighing the possibilities of the risk of treatment failure. You can kind of tell them that, probably over 95% of children are going to be cured. This is a little bit more convenient, less likely to have side effects with the shorter course, and sort of give that option to return to care or have an extension of therapy if it seems like they're failing. So overall, I think it adds a lot to, even though it doesn't completely answer the question, it adds a lot to how we can talk about this in children with their families.
Did you feel that this short course study fell short? Anyway, okay.
Excellent.
Well, the article Autonomous Leprosy, United States was published in the New England Journal of Medicine. Imagine that. Not sure how many of our listeners have seen or treated cases of leprosy, so a bit of background is perhaps warranted. Historically, leprosy was thought to be transmitted exclusively through extended, close human-to-human contact, with infection acquired during brief travel considered to be exceedingly rare. Now, in the 1970s, the 9-banded armadillo was identified as a zoonotic reservoir of Mycobacterium leprae, which has been implicated in autochthonous leprosy among persons born and living in the United States. However, autochthonous leprosy, I'm going to try to figure out how many times I can say that word today, without armadillo exposure has also been reported. The long incubation period of leprosy often makes it challenging to pinpoint the exposure source. So this is the report of 6 cases of autochthonous leprosy in U.S.-born men, mean age 68.3 years, that were diagnosed between 2017 and 2022 in California. So remember, these are folks that got it just living here, not traveling. So no patients had known exposure to an infected person, and one patient reported armadillo exposure more than 50 years earlier. I wonder who got that history. All 6 patients reported international travel, and most reported domestic travel to the U.S. Gulf Coast. The interval between the initial clinical manifestations to diagnosis ranged from months to years. 5 of the 6 patients were older than 65 years of age, and all had multi-bacillary infection. So lots of mycobacterium.
Yeah, that's really interesting. And then I think I'm wrapping up our bacterial section with this next one, the article Management of Pediatric Pneumonia, a decade after the PIDS IDSA guideline. This was recently published in CID. The purpose of the study was to evaluate the impact of the 2011 PIDS IDSA Pediatric Community-Acquired Pneumonia CAP guideline by looking at about 300,000 children from a national administrative database of children's hospitals, or the FIS database. So the biggest change authors found was an increasing uptake of aminopenicillin prescribing. I did try to pull out some of the numbers just to give people some reference. So for children who received an antibiotic during their encounter, aminopenicillins were given to about half the children hospitalized with CAP, and an average of 15% of children's discharged from the ED. I also thought the info about obtaining blood cultures was interesting. So this was done in 8% of children with CAP in the ED and 45% of children hospitalized. And as people may know, blood cultures are recommended in the guidelines for children that are requiring hospitalization that are considered moderate to severe, but there's not really a great framework for exactly what that means. So I think it makes sense that this might get applied in variable ways across different centers. One thing that was, I think, a little bit disappointing is that there really weren't changes in chest x-ray orders, which also not too surprisingly rebounded a bit with COVID, but there also really weren't changes in clinical outcomes that they looked at either. So the authors concluded that these results suggest the need to consider implementation strategies to meaningfully change clinical practice for children with community-acquired pneumonia.
Yeah, so they make these nice guidelines and nobody pays attention.
Check them out.
All right, maybe that's what the ID Puscast is about. By the way, 12 years ago, just in case you weren't paying attention, the PIDS IDSA came out with some guidelines 12 years ago. All right, time to read those. All right, moving into the fungal section. And how many do we have here in the fungal section? Just one.
I think just one.
The article, the added value of 1,3-beta-D-glucan for the diagnosis of invasive candidiasis in ICU patients, a prospective cohort study recently published in the journal Infection. In this study, ICU patients receiving empirical echinocandin treatment for suspected invasive candidiasis, serial beta-D-glucan testing using the Fujifilm Waco beta-glucan test was performed starting on the first day of echinocandin administration and every 24 to 48 hours afterwards. Now, I suspect many just read that sentence and moved on, but let me pause for a second to bemoan the bygone days when all the Fungitel testing was done in a little mom and pop shop on Cape Cod, or so the legend goes, in East Falmouth. What is this Fujifilm Waco beta-glucan test that we're ordering? A little moment to talk about horseshoe crabs, blue copper-based blood, and how this assay works. The Limulus reagent, which is a Limulus amoebocyte lysate made from the extract of blood cells of horseshoe crabs, reacts with the 1,3-beta-D-glucan just like it does with endotoxin. So hoping some bells just went off, but if not, the beta-glucan test exclusively measures the concentration in serum or plasma through a kinetic turbidimetric assay, taking advantage of this phenomenon. So don't worry, as one can still send off their test to Associates of Cape Cod in East Falmouth, and according to their website, Russia-Ukraine Conflict Business Continuity Statement, Associates of Cape Cod Incorporated confirms that the Russia-Ukraine conflict currently has no impact on the ACC product manufacturing or service provision, and ACC does not source raw materials or critical agents from that geographical area. All right. Well, in the study of 174 ICU patients, 25% classified as cases of IC were included in the study. Initial beta-D-glucan BDG testing showed moderate sensitivity, 74%, poor specificity at 45%, for which IC, which could hardly be improved by follow-up testing. While raw beta-D-glucan values or test results obtained with very high thresholds improve the predictive performance of the multivariate logistic regression model in neither single nor serial testing, with the manufacturer proposed low-level cutoff showed substantial benefit. So they concluded, as cool as all this sounds, that in this study of critically ill intensive care patients at high risk for candidemia or invasive candidiasis, diagnostic accuracy of the BDG testing was insufficient to inform treatment decisions. Improved classification was only achieved for cases with very high beta-D-glucan values.
I'm glad that just confirms what I already thought.
You never liked the Fungitel test to begin with. So.
Well, in this specific
for
setting,
Sara.
I think my heart started racing when they were talking about doing it daily.
Isn't that crazy?
Like
I think they did every other day. You're like, oh my gosh, what are they doing?
Goodness, yeah.
All right. Parasitic, be sure to listen to This Week in Parasitism. We've got some great cases. The article, Selection for Insecticide Resistance Can Promote Plasmodium falciparum infection in Anopheles, was recently published in PLOS Pathogens. We plan on doing a deep dive on This Week in Parasitism for those interested. They have a really nice author summary, so I'm just going to run through it. Insecticide resistance poses a severe threat for malaria control. Resistance to pyrethroid insecticides, the active component of most insecticide-treated nets, is now widespread in sub-Saharan Africa, reducing the efficacy of these crucial tools. Despite significant research characterizing insecticide-resistant mechanism, it remained unknown how these traits might influence Plasmodium falciparum infections in the malaria-transmitting Anopheles mosquitoes. So these researchers established a pyrethroid-resistant and pyrethroid-susceptible population of Anopheles gambiae, derived from the same genetic background, and performed experimental infections with P. falciparum. They found that the pyrethroid-resistant population was more supportive of malaria parasites compared to the susceptible population. They actually even figured out what the mechanism was. So it looks like with all this insecticide use, we have actually created a super Anopheles for the Plasmodium.
And this one, my next one, it's a little bit of a low-hanging fruit because I've been, as I mentioned to everyone, moving. But if you have somehow not heard about this, I will be glad to tell you from the CDC, there was a health alert network, health advisory for locally acquired malaria cases identified in the U.S. I do feel like this has been picked up and is on like every news website now. But if you missed it, the CDC issued this because of identification of locally acquired Plasmodium vivax malaria cases in Florida and Texas within the last 2 months. There were 4 cases in Florida within close geographic proximity, and there is one identified case for a patient in Texas. So there are some general reminders in the advisory about having malaria diagnostic tests available, also with qualified personnel to interpret them, and either having stocked or a good emergency plan for obtaining IVR testing.
All right. And now this should be included in everyone's differential of a febrile illness. Yeah. All right. So we will wrap it up with a miscellaneous. The article, Nanoplasmonic Amplification in Microfluidics Enables Accelerated Colorimetric Quantification of Nucleic Acid Biomarkers from Pathogens. All right. So pretty much that covers it all. Recently published in Nature Nanotechnology. All right. So the authors start with the background statement that molecular diagnosis based on polymerase chain reaction, PCR, strongly depends on lengthy protocols, costly reagents, complex equipment, and highly trained staff that like to get paid lots of money. That part was mine. In contrast to PCR, methods based on reverse transcription loop-mediated isothermal amplification, RT-LAMP, and rolling circle amplification, RCA, are mainly capable of amplifying RNA DNA in a one step at a steady temperature. So good so far, but then we dive into the deep end of the pool as they present a molecular diagnostic platform that integrates a fabless plasmonic nanosurface into an autonomous microfluidic cartridge. All right, gets a little complicated here, but let me just translate all this. They are doing nucleic acid amplification using a method that is 9 times as fast, super sensitive, very accurate, gives us a molecular answer in 13 minutes. The phenol red from fuchsia to yellow in less than 10 minutes, and we get a 13-minute sample to answer turnaround time. The figures are great for understanding what they're talking about.
I mean, it's pretty cool. We just ended on nanotechnology. Well, that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We'd love to get your questions, comments, paper suggestions. Send them to puscast@microbe.tv. And we do not mind if you shamelessly plug your own paper. If you like what we do, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.